Dr. Amit, I think you are muted, so you'll have to unmute yourself first.
Yes. 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 Okay, can you see my screen now?
Not yet.
Yeah. Is it
we see you now? Yes.
Yes.
Okay. You're able to see the screen, right? And I'm audible too.
Yes, you are.
So, this was a lady who came in a year back. I saw it's an 83-year-old lady, non-diabetic, hypertensive. She came with classical unstable angina, chest pain at rest, and she was otherwise a very active lady, 83 years, but pretty active for her age. And we ran through a troponin, which was positive. I'll show the ECG, of course. Clinically, no gallop. She had aortic ejection, systolic murmur, the pressures being around 90/60. And the echo showed the LV hidden basal lateral wall. The inferolateral wall was akinetic, but with preserved thickness. And the apical segments were severely hypokinetic, the ejection fraction being 30%. She had mild degenerative AS if we use the present criteria, the peak by mean gradient being 40/24. The aortic valve area was 1.8, wasn't so bad. She had some mild mitral regurg, no significant PH. She was started on inotropic support, seeing the pressures, and her EGFR was reasonable for 83-year-old. She was around 55 ml or so. I'll show you the ECG. Now, this was the ECG on presentation when she came to us. So having said this, we immediately moved her to the lab looking at this ECG, for we feared that this is likely to be a left main. And this was the angiogram shoots that we took. So as you can see, it's a distal left main bifurcation lesion, almost like a Medina 111. Distal left main is critically narrowed, ostial LAD, ostial circumflex. And there was a OM which was totally occluded. The circumflex continued distally as the major OM, which was totally occluded. And this was the cranial view, again showing the criticality of that distal left main lesion. And there was another lesion in the mid LAD, which was around 70%, which I felt best in this view, and very calcific vessels otherwise. So looking at this angiogram, of course, and I did this was the aleocaudal view, again showing that the ostial circumflex is narrowed, and the distal OM continues, and it was totally occluded, and it was seen to be filling up retrogradely from the right coronary. So this was the angiogram which I saw, and we had started on inotropes. The pressures had come up to 100, 110 after the angiogram. And the contractility looked okay. She was quite a, not at all a frail 83-year-old. She was a very fit, active 83-year-old. So I discussed this with the surgeon, and he was called in, and he said, yes, looks reasonably okay. And I think we can plan her in the next 48 to 72 hours. So having said that, we moved her back to the PCU, and she was being stabilized. Everything was going well. The next day morning, actually, we had some cases lined up for OCT at that time. And just that time, when we were about to start, I got the message saying that her pressures have again plummeted, and inotropic supports have gone up. And the ECG also shows significant ST elevation, AVR, and reciprocal dispersions in all the leads. So clearly, I knew what I was in for. And her nephew happened to be a cardiologist in US. So he immediately said that, okay, well, let's not waste and deter time here, and let's just go ahead and revascularize whatever moves. Obviously, surgery was now out, considering her present symptoms and worsening. So I thought of taking her up for a PCI. Now, of course, I was lucky that time we had a complex case symposium sort of a thing. I had other colleagues in the lab with me, particularly Dr. Brian Pinto and Dr. Anand Rao were around. So I was, more than ready to take this case up. And we said that we will open this artery and we will see how things go. So with that in mind, we took her up for the for the PTCA to the left main, the LAD. there were different thought processes which came to our mind. One of them was, should we do a bifurcation here since it's a 1-1-1? But considering the pressure is again 100/60, whether we should just tackle the left main, the LAD seemed to be reasonable because the OM was anyway a CTO and it was well collateralized from the right side. So should the final consensus we took was, let's keep it provisional and just tackle the left main to LAD, and we'll see how the circumflex behaves. If there's anything, then we can always convert it to a 2-stent strategy, as in a tap or so. If the angle was pretty favorable and wide for a tap. So keeping that in mind, we first went ahead and I did a balloon dilatation with a 2O balloon to just get a feel of the lesion and the calcification around. It opened quite well at about 15 atmospheres. It was quite a good lesion. But again, after that 2O balloon, the pressures came up quite nicely, and she looked a little more stable relatively. We had the OCT, as I told you, for other cases that get called. So we decided, let's do an OCT and see the calcification, particularly whether we'll need a rotablation or should we just go about and just do the case with debulking with a flextome. So initially, then after that, we upgraded the balloon sequentially. First was a 2O, then we used the NC Trek 312, and we opened the lesion first. And subsequently, this was the OCT we did. This was the pullback, starting from the distal LAD. So you can see a lot of fibrofatty plaque there in the mid-distal LAD. And as you start coming up, notice that calcification there between 9 to 12, quite significant. And then as you start nearing towards the left main, you can see that there is a thin cap fibroadenoma there with some thrombus and of course fibrofatty plaques in that area. The body of the left main looked reasonably good. It was not so diseased. Of course, this cannot comment on the ostium, but the body of the left main looked very disease-free to me. And I thought that we could get away with the left main LED. So this was what was the areas that we came out. The left main, if you see the body, the diameter was around 3.9 on the OCT, and the area was about 12.1. This was the most critical part that we saw of the distal left main. The area being 1.8, hardly being any space there. The proximal LED was around 5.6 millimeters square, and the mid-distal LED, surprisingly, this which looked angiographically around 20% or so, was quite critically narrowed. And the lumen there was diameter there in the OCT was almost 3.2 mm, and the area, of course, was 2.9. So there was a significant plaque burden, but it was more of a fibrofatty plaque down there. Whereas if we see the left, so just in mind, we saw the OCT. Now again, the calcification did not look that bad to warrant a rota, at least. And with such a lady, 83 years old, and with the pressures of 90, 100 on inotropes, and we thought it is better to debulk using a flextome and see. So we went ahead with a similar this thing and used the NC 3.5 balloon, followed it up with a flextome 3.510, and went up to about 10 atmospheric pressures slowly. And results were good. And I got in the first stent, which was a 3.5 38 millimeter, covering the LAD lesion first, and secured that. And in the left main, as I said, on the OCT it appeared around 4.2, but on angiography it appeared anywhere between 4.5 to 5 was my feeling. So I got a 418 stent there, overlapping with the LAD stent. And I left the ostium because I thought it was reasonably disease-free, and I just needed 8 to 10 millimeters for my pot, was all that I needed there. So I positioned the stent just shy of the ostium, and of course then did a pot there. This was then upgraded. The balloon was the proximal LED was upgraded to a 4.0. I post-dilated with a 4.08 balloon, and also the left main was post-dilated to 4.5 mm balloon. And this was the final result. Now, all this time during doing the procedure, we were looking at the circumflex ostium, and I thought maybe after the stent there was some pinching there, clearly visible, especially in the aleocaudal view. Now we were thinking whether should we really do something. It was quite okay. The pressures were doing quite well. ECG did not show any acute changes, and I thought we had a reasonably good result on this. And so then we decided to leave the and probably come back to it at a later day, because finally, after having secured this, we thought the questions did come out quite reasonably well. And we left it at this. We did a final pullback of the OCT to show a well-deployed stent there. Now, there was some malapposition at the most critical site of the lesion, the distal left main. Now, this was again post-dilated with a 4.5 mm balloon, and to restore the adequate expansion there in that area. And the patient did reasonably well. So this was what the areas I got on the left main, where the stent began, the body of the left main. We got a area of 14.8, and the reference area there was around 15.5. So clearly it was quite, the MSA was pretty good, more than 75%. And similarly in the proximal LED, the area was 8.8, and LED about 8.2, and the distalmost part the stent ended, it was around 7.1. And the reference diameter there was around 8. So I thought we had a reasonably good expansion of the stent there. We decided to leave the circumflex there and probably not this thing, because she improved significantly, and she was subsequently discharged on day 4 or day 5. In fact, we didn't even feel the need for putting a balloon pump. The pressures came up so well after doing the upgradation of that balloon pre-dilatation. She did quite well. And we thought we better leave it here. So, elderly lady, fragile hemodynamics, and a distal left main bifurcation lesion. I thought that was a perfect recipe for having a lot of action here. But the surgeon was ready to pick up the case, and I was also relieved. But this happened the 24 hours after being in the CTO. I think the LCX CTO made a good decision, and PCI more favorable here, because that let me keep my probably as a provisional approach. And of course, we had the OCT that time, so I thought the stent optimization would have to be a must. All this time, we kept a look at the LCX option, and we're ready to change the strategy to a tap, anything. But I felt that, given the OM being total, I think it was avoidable at this stage. And we know that IVUS is preferable in such lesions, especially in such huge left mains. IVUS definitely beneficial, but we could not have it that day. But we were able to get a good imaging there, particularly. We used the pressure injector, and also the imaging decided the strategy, and it did not need to have, I thought, calcification would be immense on the angiogram. On the OCT, we were surprised to see that it was not more than 90 to 80 degrees. Thank you. This was the case.
I think, good, very good case, Amit, in terms of planning the procedure, and most of the steps you did were the right way, and you got a very good result. And like I said, the circumflex also was not a great vessel. The RC was a huge vessel. There was no point chasing that artery at all. Ronnie, any comments on the OCT runs?
Yeah, Amit, it's a very good case, but I think, just a difference of opinion, I would probably have done a PCI as a first choice in this lady. She's 83 years old, and she has got a right coronary that's decent. Distal L-Sucks, that is a CTO, we don't need to bother about that, because that's filling very well from the right. So I would probably plan this and go for a two-stent strategy on the left main to LAD to a certain and I think on the OCT, the mid-LED showed a lot of eccentric calcium. And eccentric calcium, you cannot do it with a rota or an IBL. And I think what you did was excellent. Probably the only thing that I would do differently is look at the LSUX scheme on the OCT from here and probably go and do a tap onto the circumflex also, because I think that is the left main to the circumflex needs a little bit of opening, and you cannot open that in a pot unless you go and secure your circumflex.
Circumflex. I agree with you, sir. Yes. And the circumflex also was a decent sized vessel. It was 3+ almost. So yes, that was weighing on my mind. But all the time when you see 83-year-old and you say, no, let's just secure that left main LED, and that kind of thing was playing on my mind. And yes, I agree with you that and hindsight, I also feel that maybe I should have done a tap and probably got that also, because
if you have an OCT on the shelf, you can very safely go into the left bifurcation, distal bifurcation. You will never land in a problem, because you sit once you got your wire in the circumflex and you've done a crossover from left main to LED, that wire is jailed. And now once that wire is jailed, you always know where to go and open your L-Sux ostium, even if the L-Sux ostium is not. And if you've got a large opening, you will know where your distal crosses, and you can always open it and secure it. You'll never have a problem.
Yeah. I think the only other thing was, would you have? I thought there was a little under expansion at the distal end of the left main, even on the OCT images.
Angiography. Yes.
Angiographically and on the OCT. I mean, we didn't run the OCT to that segment, but if you look at the OCT cut at that area, there seemed to be probably it's a large plaque burden there, but a little under expansion of the stent. Not a malapposition, but an under expansion.
Under expansion, yes.
At that point, I think
it's primarily because there's probably eccentric calcium over there. You can see eccentric calcium on the OCT right now, because it is dilated. This was a dissection over there. And what you see is a dissected plaque there. So between the dissected plaque, there will be a calcium that you can't see. But you can see the calcium once you go and do an OCT post-stent. If you go and really nudge it open, you will be able to nudge it open only with the circumflex. That is, open the circumflex. Without that, you cannot go and open that. You may cause a problem to the circumflex.
Any other comments? Otherwise, we'll go on to the next case. Okay. Let's go on to the next presentation. That is Dr. Prasad Shah. He's going to present a case on bailout SKS procedure in a patient with calcific distal left patient following burr entrapment during rotational atherectomy. Prasad, over to you.
Yeah, sure. Thank you so much, Ajit, and hello, Ronnie, and hello, everybody. Screen visible?
Not yet.
Is it visible now?
No,
Girish, no, not yet visible. Not yet visible.
Hello, sir. Just try to share your entire screen, sir.
Share the entire screen.
Yeah. So when you click on share screen, the first option that is there, your entire screen.
Yeah, it is highlighted.
Yes, sir. Then click on the share button. Then click on the share button, sir.
Did that?
Oh, we don't have it yet, sir.
Okay, let me go back again. Share screen.